MRD stands for Minimal Residual Disease, and some people say it's a more appropriate called Measurable Residual Disease. So basically, it depends on the test you're using of how much you can detect. So most commonly, MRD is assessed by flow cytometry, which is a sensitivity what we call 10 to the power minus 4, which is that a test can detect one CLL cell in 10,000 normal cells. And that's traditionally recognized as a standard criteria for patients with CLL. And if someone has a number of, at this test, which can detect one cancer cell in 10,000 normal cells, and we do not see a cancer cell, we call them, these days we are using the term undetectable MRD, and you many times will see that in the publications in the report, it will say U, undetectable MRD4, which infers that this is an undetectable MRD at the level of 10 to the power minus 4, because there are tests, we can go much deeper, 10 to the power minus 5, 10 to the power minus 6. So again, it will be important to kind of see what the sensitivity of the assay is. But as I said, most commonly used is undetectable MRD 10 to the power minus 4. So at this ASH meeting and previous to this ASH meeting, I think there have been significant efforts being done right now to have time-defined, time-limited treatment duration with the goal of achieving deep remissions, deep undetectable MRD4 remissions, and then be able to stop therapy. So one strategy which is being pursued in many trials is a combination of ibrutinib plus venetoclax. So Peter Hillman presented yesterday the data, very exciting data, I would say, in a relapsed refractory patient population, combining ibrutinib plus venetoclax, and actually the progression-free survival and overall survival curves were spectacular. And actually, I was really impressed with the data he presented. And I think, and that shows us that these patients are achieving deep remissions and they are not progressing. We have been doing a similar study of ibrutinib plus venetoclax in frontline patients as well as relapsed patients with CLL. And we reported yesterday the frontline 80 patients. And again, we saw the same thing, that we are seeing high undetectable MRD rate and complete remission rate. And our plan is to give 2 years of therapy and then the therapy will stop. So, and then we also know the data from the Morano study where patients who have a relapsed disease, they were given venetoclax and rituximab for 2 years. So again, I think the field is moving towards from continuous daily therapy with ibrutinib or a BTK inhibitor. There are other BTK inhibitors like acalabrutinib, but all of them are continuous daily therapy, to a time-defined therapy of 1 to 2 years, whether it's a venetoclax with obinutuzumab, venetoclax with rituximab, ibrutinib plus venetoclax, or other combinations in the works, but everyone is looking at this time-defined therapy. I think a big question in the field which is not yet answered and will be answered eventually is, what happens when you stop therapy at 1 or 2 years? And will the patients will start getting the MRD back or the disease back? We really don't know the answer to that question because all these trials, we are just coming to a point where patients are stopping therapy. We do have some indications from the Morano data yesterday, which are presented, where patients who stopped therapy at 2 years with venetoclax, if you were MRD positive at that time, it looks like, and not surprisingly, those patients do tend to kind of relapse. So, but I think that things needs to be teased out further as more trials kind of start reporting off-therapy data of ibrutinib and venetoclax and others, and then what happens without therapy. So, but I think that's the terminology which is coming around, undetectable MRD, time-limited therapy, and I think the field is moving away from continuous daily therapy with a ibrutinib or a B-cell receptor inhibitor.